Hi, welcome. My name is Ed Marks. I serve as the Chief Digital Officer for Tech Mahindra Health and Life Sciences and part of the HCI Group. I just want to welcome all of you to our very first webinar of 2021. And I'm thrilled to have such an awesome guest in Dr. Danza from University Hospitals, which is headquartered in Cleveland, Ohio. We're going to talk about telehealth, past, present, and future. Right before we introduce Brian, I just want to remind everyone that this is a live webinar. And the reason that we do it live is for two reasons. One is it makes it kind of fun because we never know exactly what's going to happen and gives us a lot of flexibility. But two, we're really want to engage with you as part of the audience. So while we do have some questions, we prefer to get questions directly from you. So I think everyone knows how to do this by now. You can enter your questions in the panel and we'll try to get to as many as possible. In fact, we already had 3 submitted in advance and we'll be sure to address those as we go on. So let's jump right into it. And so Brian, I would love for you, I know we have a slide right here, but love for you to just introduce yourself to our audience.
Yeah. Hi, Ed, and the audience. And first off, thanks for inviting me. It's a pleasure to be here and talking to everybody. And I think during a time that is pretty exceptional when you think of everything that's going on with digital health and telehealth. So I appreciate the invite. So my background is I'm primarily a clinician, an ear, nose, and throat physician to be in particular. And I started my training about 11 years ago at Geisinger Health System, and a system in very rural system in central Pennsylvania. And that was really where I first got exposed to digital health and telehealth. If you know Geisinger, you know it's really at the forefront of a lot of population health initiatives. And within that, they saw telehealth as a way to provide value. And from there, I went to the Cleveland Clinic, spent some time there, got further exposed to telehealth, utilizing it in my practice. And then at the end of my time at the Cleveland Clinic, I started looking around at the field of telehealth, and this is, 5-6 years ago now, which not that long, but seems like forever ago when it comes to telehealth, and got the idea of, contributing more to the field. And at that time, I worked with a co-founder to found a asynchronous telehealth company to try to take advantage of the advancements in telehealth and really push the envelope of what a doctor visit might look like. And so from there, I was a co-founder of that, served as president and CEO, and started at University Hospitals just after that. At University Hospitals, as I mentioned, I'm an ear, nose, and throat physician. I've been involved in a lot of the telehealth, digital health initiatives for a few years now, and more formally, at the end of 2019 into 2020, I was asked to sort of come on as the more official role as the medical director for telehealth and digital health for the enterprise here at University Hospitals. We serve a very large portion of the region of Northeast Ohio. We have about 2,000 or so physicians in our provider group. And so that's what I help to direct the telehealth and the digital health interactions there. And so I spend a lot of my time, speaking on behalf of clinicians and working with physicians, as well as IT folks, and participating in executive decisions here with telehealth. So really excited to be here again, and look forward to our discussions.
Yeah, and I think a lot of people already know that I have a huge soft spot in my heart for University Hospitals, where I got my first chance to really lead in a big way, and I love the organization, and the mission has ever been emblazoned on my mind. I can recite it from memory quite easily. But anyways, let's talk past, present, and future. Past for us is like just this past year. Present is now, and future is 2022. And really get some of your insights. And first, let's talk about in terms of the past, because everyone wants to know about COVID, but a lot of people have talked about COVID. So we're just going to have one question around COVID, unless the audience wants to hear more. How did you navigate COVID? You're in your role as you described. So fortunately, you started before COVID.
Yeah.
And then how did you navigate? And Brian, not to ask a double question, because then sometimes like, oh, what was the second part? But interestingly, right, what the uniqueness of Cleveland and how you partnered with what would have been formerly a competitor. So that might be interesting for the
Yeah.
audience as well.
Yeah, no, I mean, the question, always, how did you deal with COVID, and how did you prepare for it? And really, there's no way to prepare for it, and we just kind of dealt with it as it came in. And I think there were a couple things that we did that I think really helped in our response, and in particular on the telehealth side, the digital health side. Prior to COVID, we really, we had sort of dabbled in telehealth. When you think about the sort of grand scheme of how much we're using it and what we're using it for. We had some use cases, we had it in its various silos. So we had some departments using it, but it really wasn't anything that was sort of really widespread. And we were building on that. And so overnight, really in mid-March, we went from, using it maybe 2,000 visits across our entire enterprise in all of 2019 to, overnight having to stand up and operationalize and get really 2,000 providers on a platform, have the billing, having the legal challenges of figuring out day to day, what's okay to bill for, where are these public health exceptions coming into play. So all that, really came down to, well, what do we do? And so the first thing we did is we got a group of sort of multidisciplinary group of leaders from across the system, telehealth, digital health, clinicians, billing, operation leaders, really from across the gamut. And we basically said, every day we're going to meet. And we made that a priority. Every day we're going to meet, we're going to see where we're at, we're going to triage what's happened, we're going to figure out where the challenges are, and we're going to go from there. And I think that, to me, is where we had a great success in being able to take in what was a large flood of patients and doctors who needed to connect. And as you recall, in March and April, when they shut everything down, so we couldn't see patients in clinics. And so at that point, we basically said we need something to interact with our patients, and telehealth was the natural answer to that. And so that was really, one of the big things that we had was these multidisciplinary daily meetings. And I think it contributed to our success. We went from, I think in all, like I said, in all of 2019, less than 2,000 patients seen to about 90,000 in April. And so that massive expansion really necessitated a change in how things were done. We pivoted quickly in the platforms that we had to provide. We had some institutional relationships, and we basically opened the floodgates and said, listen, if there's a platform that works, if it works for you, use it, and so, obviously following all the guidelines from HHS, and a lot of those guidelines were dropped, or rather the requirements for certain platforms, and sort of open it up to allow multiple platforms to be used. So that was a big thing, and I think really helped us see and maintain our connection with our patients. And I think we did an excellent job of that. The other question, I think, about working with our competitors as opposed to against really manifested itself in many ways. We worked with the Cleveland Clinic to set up a sort of drive-through testing spots throughout the city that were really worked on by both of our teams. The leadership of both university hospitals and the Cleveland Clinic really worked together to set up those clinics, to set up other sort of fever clinics, and other points of evaluation that really helped get a handle on what needed to be done. And that initial surge, I think we were able to reduce that and really ameliorate any effects of it because of that relationship with the Cleveland Clinic, where we really started working together. And we had done small things together in the past, but this was definitely a bigger wave. And it was one of those sort of silver linings that has continued with further partnerships really throughout the last year.
Yeah, that's a great story, and how you came together as a city. I'm really it's a bright, like you said, a silver lining, bright star amongst
Yeah.
some dark times. So that's sort of the past. And as we sort of morph into the present, tell me the other thing people want to know. So you had these daily huddles and you met and you worked your way through the crisis. So in the present, now that things have stabilized somewhat, I'm assuming, correct me if I'm wrong, how are you continuing that path? And then again, I'm going to throw another double question at you, but I'll remind you if we don't get to it. And then you have the opportunity to serve with one of the best CIOs in the country, with Robert Erdley. And so how do you work, with your IT colleagues?
Yeah. So good question. So I feel like the present, obviously, we're still going through that transition. And I think the primary thing that we've thought about through this whole process is, we have that sort of emergency time in March, April, May, where we're basically looking for a lifeboat to jump into, which was telehealth. And so we saw that as something that needed to happen. And that required a lot of different sort of initiatives and things that I mentioned with multidisciplinary meetings. But we always had an eye towards, okay, where do we go from here? Because we knew that this was something that was needed. This surge in telehealth and digital health initiatives was needed because of the circumstances in the short term. But in the long term, we always saw this as something that was going to be sticking around in one way or another. And so what we found, is that as we've been working through the day-to-day, we've also been planning for the future. And there's a few things that kind of come to mind as to what we've been working towards when we think about the present. The first is, we talked about, sort of opening it up to, you can use any platform you want to see patients, anything you want, just as long as you can get in touch with them. That was a great sort of tactic during the emergency. But as we emerge from this and we start thinking about, the benefits of our system and working as an enterprise and integrating some of this technology, then it becomes a different idea of, well, how do we maintain that connection with patients? And, how do we improve on the quality of the care that we're providing? And we're not just replicating care, because that really gets to the goal of a lot of what we're trying to do with telehealth long term, is that we're not just, replicating seeing the doctor, in the office, but we're wanting to improve the quality and the value of care. And so that was really, I think, a goal of the present. And, working with our IT colleagues as we've started to go down that journey has been vital, because, we start talking about ways that we can integrate telehealth into our different digital platforms that we already have, whether it's, most importantly, our electronic medical record, or if it's billing systems or scheduling systems, improving our access. And so that's been really essential. And, I think that when we think of, longer term, some specifics of what we're looking to do is, giving a full integration of our telehealth and digital health platforms into our EMR, where it's not a sort of a separate piece, but it's part of it. I think that, as far as some governance changes that we've gone through, in really hardwiring that connection between our IT colleagues and digital health and our operational leaders. That's been something that I think is becoming more and more mature as time goes on. And I think a lot of this is really still in development, but I think that it's all really part of where we need to talk further about to get to where we want to go with having digital health being really, in a way, kind of part of the fabric of our health system, and part of the way that we see patients and that we have our doctors connecting with our patients.
Now that's great, and really good advice on how to work with IT colleagues. So we have questions. So if you have other questions, please, as I mentioned early on, you can enter those questions into the side chat, and we will certainly get to that. One of the questions that came from a physician colleague in Europe is really, and it's part of the present, maybe part of the future answer, is the clinical effectiveness, and so we're moving beyond COVID, but you could use whatever example you want, but clinical effectiveness and cost effectiveness. So how do you see telehealth? How do you view telehealth, when it comes to the clinical efficacy and as well as sort of the cost
Yeah.
side?
Yeah, and I think that's a really important question because it gets to the whole idea of value-based care, and improving the quality of care while also reducing the cost. And when I think of the different ways that we use, and I'm just going to go a little bit more general than telehealth, we think of that sort of direct interaction, that direct care delivery. I think that's one way to think of it. And to me, there's sort of four basic ways that it improves that sort of value sort of idea. One is that telehealth, it has been shown to really reduce the need for recidivistic care in circumstances of acute medical problems. And the data for this is there. I think as a caveat to all this is I think one of the challenges we have is really improving the data when it comes to telehealth and cost effectiveness. There's plenty of room for improvement. And this gets back to, the fact that telehealth has been limited up until recently. So I think we've got a lot of work to do in that respect, and maybe we can come back to that later. But, it has been shown in some studies to reduce the need for recidivistic care by up to 50%. It can also reduce the need for unnecessary testing, shown to reduce the rates of laboratories ordered, like blood work ordered, radiology testing, and then also increasing patient satisfaction. That'd be number three. And finally, and I think this is one of the most important things, is telehealth reduces those barriers to care. So when we think of cost effectiveness, a lot of times the initial response is, well, I don't get paid as much for a telehealth visit as I might get for an in-person visit. Now, some of that's gone away, and that's been a big reason for why it's been increasing so much, is a lot of the legislative issues surrounding that have dropped to the sideline, and there's a lot of parity now. But when you think about barriers to care, we think about no-show rates, we think about patients unable to get access to care. And what we all know is that the less care that a patient's able to get before they get to the hospital, the longer they're there. And the higher chance that their presenting issue is going to be more severe. It's going to cost more to take care of them. And so telehealth, one of its biggest benefits is improving that access and all the things that come along with that. So I think that's a big part of it. I think, it has been sort of monetized, and there's numbers associated with that. And we're talking about on the order of billions of dollars that could be saved with adequate access and better access to care facilitated by telehealth initiatives. So I think all that is sort of encapsulated in improving the cost effectiveness of care.
That's a very good point. Yeah, I love that. So we are a little bit over halfway through. The time goes by really quick. Just one last reminder to the audience, you can ask questions. I do see some audience questions come in, plus the ones that have come in before. So let's just keep rolling with some of the audience questions. So another one is, how do we support and promote telehealth in the future? Because Brian, I'm assuming that you've seen, given your experience and your passion, that you're a big proponent. And now that we've went through this pandemic and people realize, wow, this works and is effective in the ways that you shared, how do you propagate this? How do you continue down this path?
Yeah. I mean, so part of it, Ed, the nice thing is it's probably going to propagate itself, and because patients like it, and patients want it. And so, part of it is going to be, there is going to be kind of a natural progression there. And I'm sure that, we've all seen that Forbes article that showed sort of that kind of parabolic curve of telehealth visits and, uptrending up to 2025 when they might outpace the in-person visits. Obviously that changed quite a bit. And so part of it will be natural. And I think for me, the reason to mention that is that we need to build the environment that is going to allow that to happen most seamlessly. And we like to describe it here at University Hospitals as an ecosystem of sorts. And so there's a number of things that go into that. I think one of the biggest things is integrating the sort of legacy systems that we have in our electronic medical records, billing, marketing, whatever it may be, into these new sort of initiatives and these new platforms in telehealth and digital health, and making sure that that sort of transition from a patient walking through the digital front door, which in many cases is a portal, to seeing a provider, or being triaged or engaged to interact with our AI chatbots or other triage means, patient engagement platforms, and then leading downstream to an actual provider patient visit. I think that is it really important we make that as seamless as possible, and part of that's going to be integrating all those systems together and doing it in the right way. I think the second thing is really seeing digital health as not a separate strategy, which for practical purposes it has to be in many cases, but making it part of the healthcare strategy, in that how do we take care of patients the best way? How do we make sure patients are engaged and are promoting good behaviors and improving their healthcare before they hit our doors or even our digital front door? And so having that separate strategy is many times needed to begin with, but really having the overarching idea that we want patients to get better, whether it's digital health or otherwise, whether it's a telehealth visit or an in-person visit. And so part of that, I think, is what I got back to when I was saying initially, was getting some data that tells us, okay, what is the right profile, or patient profile, to be treated through a telehealth visit. And let's take it for, let's say, a synchronous telehealth visit versus an asynchronous telehealth visit. What's the right patient that frankly just needs to come in? And once we start parsing that out based on the data, then we're able to kind of get away from this idea of, well, how do we propagate digital health just for the sake of digital or telehealth? But how are we taking better care of patients? And part of that is going to be digital and telehealth because of all the benefits we know. And as we get more data, we're able to see that improve in sort of the accuracy, the preciseness of how we take care of patients. And so university hospitals, our goal is really to keep patients healthy at home. It's a mantra that we have these days, keeping patients healthy at home. Mm-hmm. And so how do we get to that? Whether it's telehealth means, whether it's digital tools, whether it's nurse navigators on phones, the goal is the patient. The goal is getting the patient healthy and looking towards value, providing that improvement in care, and also being mindful of the cost associated. So I think that's all part of it. I know that's a long-winded answer to your question, but I think it encapsulates it.
No, that's packed full of great insights, especially because I'm really big into strategic planning, and especially the one that just be part of your overall plan of your healthcare system and stuff. That's good. So I'm going to ask you a forward-looking question, because we did say past, present, and future. And then we're going to come back. There's several audience questions that respond from our discussion on, or what you talked about, reducing the barriers to care. So I'm going to come back to those in a second, but I want to make sure we get a little bit about the future, because you said something that was another, a diamond there that you left us in the last answer about your university hospitals wants to take the best care of you at home. So have you thought about, like, how many possible, I don't know how you look at it, Brian, so you answer in whatever metric you want, but sometimes I would look at it as in how many percent of inpatient days can we actually move to the home, or how many admissions can we prevent and just take care of people in the home? What's your thoughts, University Hospital's thoughts? Obviously you thought about it because you mentioned it, around that.
Yeah, it's a great question, because what we're talking about now is metrics, right? We're talking about what metrics are we using to sort of monitor how well we're doing with telehealth. And so, one of the metrics we use is readmission rates. And so patients who have discharged from the hospital, they have to come back within 30 days. That's a metric on many different areas. We have an ACO program here at university hospitals, and something obviously we pay close attention to. So that's one that's obvious. I think utilization of the emergency room and ED is another one. The emergency room is that sort of backup, care that you only use if you really have to. And for many parts of the country, and Cleveland is one of them, it's utilized because they can't, you can't get access to a primary care provider. And so that's a big part of what we look at is, utilization of the ED. And attached to that is also, days to first available for providers, for primary care providers or others. I think I saw a data point the other day that said, the 15 largest metro markets in the country, it takes on average about 24 days to see a primary care provider. That's a metric that's disturbing because, we've also shown that when it takes longer to get in to see your primary care provider, you end up in the emergency room. And so, I think that's a really important metric as well. Moving beyond those, a lot of the sort of more obvious ones, we also have started to look into disease-specific metrics. So when we think about, value-based care, a big part of that's preventative care. And, amongst preventative care, some of our most morbid conditions in the United States, we talk about heart disease, hypertension, and diabetes. And so, we've started to look at some of our programs here, and one we use offhand is a program called Conversa, which is a patient engagement platform that we've utilized to really improve our engagement with patients and reaching out to patients after they've been admitted or even before they've touched our healthcare system in a more formal way with a visit and looking at, for example, their A1C levels. And following their A1C levels. A1C levels, are basically a way that monitors their glucose or their sugar levels over time, and it's been associated with morbidity and complications otherwise of diabetes. And so that's an example of an AI chatbot program that the metrics we've been following for that are more disease specific. Same thing with heart failure. And looking at specific, laboratory or otherwise metrics for that. So, there's a lot of different ways that we measure it here, but that's just kind of a flavor of the different ones we're looking at right now.
Yeah, that's great. Hey, we're down to 2 minutes, so we're going to do, Brian, what I call speed round. So, because I want to hit a couple more audience questions. So you have like a 20-second answer. I know maybe and I don't think these are not overly complex, but I do want to hit them. Yeah. So we talk a lot about telehealth and all the benefits, but we know that there's rural areas, including the broader Cleveland region. And even within the city, there's areas that don't have access, right? Broadband access, things like that. So what's one thought on how to improve telehealth in rural areas?
Yeah, no, great question. So broadband access is a problem, and I think what the question is getting at is it actually can worsen health disparities if not used in the right way. So there's two things I would say to that. One is that we need to think outside the box of what is telehealth. So people think of synchronous telehealth where you need a broadband connection. Asynchronous telehealth, on the other hand, text chats, AI chatbots, sending emails, etc. That's one way. The second way that's been shown, and this is something that we're advocating for on the federal level, is a better idea of telephone visits being a part of telehealth. And that's something that needs to change legislatively. And I think that also has the opportunity to improve access in areas where they don't, and reduce those disparities in health that exist across many different lines. Okay.
One last 30-second question, because we do have to end on time. And I'm going to combine a couple together, but I know you'll nail it. Payers, what do you see the future with payers? Are they going to continue to follow the CMS lead, or what's going to happen?
Yeah, no, I mean, payers, we shall see. I'm guessing the pressures once the public health emergency ends will be such that it really promotes them to accept the changes that really inevitable. Trying to go back to the way things were, it can do damage, I think. So I certainly hope. I think it will be a little bit of a gradual process, but I'm hopeful that they will kind of see the light that is telehealth, that it can help improve, the costs.
Brian, this has been awesome. I mean, I'm still old school when I take notes. I took down tons of things to learn. Thank you so much for being our guest. You were awesome as I expected. Great institution. You're a great person and great leader. And thank you for all that you do to protect and bring healing to people, to teach, to heal, to discover.
Yeah,
So
no, you got it, and I appreciate it, Ed. And I'm happy to be here and look forward to further conversation.
great. So thank you, Brian, and everyone. Last 10 seconds. There's upcoming webinars on patient experience, digital transformation. We have CFO perspective, as well as our continuation on race relations. So don't miss any of this. We do these for you, commercial free. Thank you, everyone. Bye now.